consider you as the father of pediatric nephrology genetics in India. And looking forward to your talk.
Next time, we will get a payment of father.
Good morning, all. Thank you, ma'am, for the very generous statement. But I think what I've done is quite less as compared to what was what in the realm of genetics is. It's a rapidly progressing field, and we need to keep updated ourselves. And a difficult, the category of kidney disease where genetics is very complex is in the CAKUT, and that's why probably Dr. Rajesh put that question mark to that. Is it really useful in a clinical setting, or is it just for academic and research purpose? I mean, something I call as intellectual gymnastics to see what is happening in CAKUT. So I'll be going through these points. I mean, just generally starting with a general discussion on CAKUT and the basic concept of kidney development to understand the complexity and probably give you some insight into why clinical genomics is something that really challenging, and also give you a brief update on what has been found in the genetic testing of children with CAKUT and why it's not being used, as I said, in clinical settings so commonly as other kidney diseases. So as you all know, it's an umbrella term. We never know why this term came up in first place. Apparently it's by some Japanese group or someone who came up with this umbrella term of anomalies of kidney and urinary tract, basically describing the spectrum of anomalies of the kidney and outflow tract. And many of these anomalies are basically structural without much consequences on the functional abnormalities, which means that many of them may go undetected throughout the lifespan, or may be detected very instantly when you are doing an ultrasound for some other purpose. But CAKUT is indeed a common congenital malformation detected by routine fetal ultrasound. To more than 1/3 they have identified as CAKUT. And spectrum, as I said, can be isolated or, as we heard yesterday, may be associated with other extrarenal malformations or syndromes. And an important fact is that the morbidity associated with CAKUT, in fact, if you take the end-stage kidney disease children, more than up to half, or sometimes more than that, are caused by one of the CAKUTs. So the spectrum is very broad. It could be a kidney phenotype, it could be a ureter phenotype, or the lower urinary tract. When I meant lower urinary tract is the urethra and the bladder, a combination of all this. And you can see here the various malformations that come under this umbrella term. One of the morphological signs is the hydronephrosis. Unfortunately, more than up to half to 2/3 of these, prenatally detected hydronephrosis are usually transient or physiological. Now, important fact to remember is that CAKUT is sometimes seen with other extrarenal features, which may be more common than what we anticipate. Probably underreported for this facts that I stated before, that many of them are structurally abnormal but functionally okay, so they may not manifest any symptoms. So practically with CAKUT, all the organs have been associated. More commonly, the CNS, eyes, cardiac, ears, and genitourinary. These are the common anomalies that you see. So it becomes important that when we see a child with a CAKUT, we look for extrarenal symptoms, and vice versa, when a general pediatrician or a genetist sees a syndromic child that is involving the eyes, ears, skeletal, cardiac, it's very important that the screen, at least using ultrasound, the kidney and urinary tract, and thereby actually enhancing the yield. So this is very important to remember, and this also correlates with many things. I mean, the extrarenal surveillance, whether you need to do a genetic testing, and also the yield of genetic testing. So we should put in a significant amount of our efforts when we evaluate CAKUT to look for extrarenal symptoms, which may be very non-specific, which may be silent, which may be subtle. So just to run you through the development, all of us know that basically the kidney and the urinary tract is formed by two structures, the ureteric bud and the metanaphilic mesenchyme, and they undergo a series of changes starting from around third or fourth week of gestation. And along with the simultaneous development is the genitourinary, that cloacal development that results in the genital development. So all these are very interlinked. So we have situations like HNF1 beta where there may be also a genital abnormality. So the crosstalk between the ureteric bud and mesenchyme is very important. And when this is disturbed in the early phase of renal development, it generally results in kidney agenesis. But when this disturbance happens much later during the development of the kidney and urinary tract in the fetal life, it can result in a loss of a lot of combinations of either isolated kidney hypoplasias or parenchymal defects, or isolated ureteric defects, or a combination of both. And as you can see, an important problem in male children, the posterior valve sometimes happens between the early mid gestation. And this development is orchestrated by a lot of molecules, and many of it are listed here. It's a very complex phenomena, and it is tightly regulated, not only in a spatio-temporal manner, but as you can see here, many of these molecular signaling pathways disappear and reappear during the development of the kidney. So depending on when that particular molecular signaling is affected, it can result in different phenotypes. A classical example is the transcription factor WT1. You know that it can result in a complete renal developmental abnormalities, as you see in Wacker, or you can result in isolated photocytopathy that you see in children with DMS or children with aneurysm and Wacker syndrome. So it's a very complex, I don't want to go into these details, but mainly to address to the fact that there are multiple factors that are involved in kidney development, and genetic or molecular factors is one. The second most important is the uterine and the maternal factors, including placental circulation, maternal nutrition. All these have been found to involve or impact the kidney and urinary tract development. So, unlike the other monogenic kidney diseases, CAKUT is a little unique in many sense. One is that you can have the effect only in one kidney, and the other kidney can be completely normal. And you often wonder if it's a germline mutation, how does this happen? And the explanations are very hypothetical and postulates, and we don't have a clear idea of why this happens, that in a germline mutation, one kidney is affected while the other is not. Second is, many of these variants, as I gave an example of WT1, can cause sporadic as well as syndromic manifestations. So, and the spectrum of clinical manifestation, right from a silent phenotype to kidney failure as early as happening in the fetal life itself, resulting in severe oligohydramnios is quite seen with the same kind of a morphological or a pattern. So you can have a kidney agenesis in one, you can have a dysplasia in the other. One child can be completely normal, the other child can have severe oligohydramnios. So, and third is the phenotypic variability within the same individual. So, on one side you have a hydronephrosis, the other side you have a duplicated or a reflux, and so on. So, there's a significant heterogeneity within the same patient exhibiting different anomalies. And also, the familial history can be quite confusing because they never seem to track the same morphological abnormality or phenotype. So, example, in a child you can have a PUV, you can elicit a history in the cousin of having a reflux, the parents of having a unilateral kidney agenesis. So, there's a very heterogenic manifestations of different anomalies, not only within the same individual but also among the family. A lot in the familial cases of CAKUT. So all these unique aspects questions whether it's a truly a Mendelian inheritance pattern. And some of the hypotheses to explain these differences are that yes, there may be a spectrum of monogenic variants seen or copy number variants seen, but in addition, epigenetics such as DNA methylation or environmental factors, including medication, maternal nutrition, placental insufficiency, all can probably contribute. And also, another important hypothesis is that it may be a secondary phenomenon, where there's a germline mutation and also a somatic mutation happening during the kidney development, which could explain the variant presentation, especially where you have an involvement of only one unit of the kidney. So this whole journey of monogenic kidney disease in respect to CAKUT started actually as not as a clear direct work. It actually was a part of a work that was, all of you have heard of the ESCAPE study, where they looked at use of AC inhibitors in controlling proteinuria. So in a subset, they had stored the samples and they did the DNA analysis, and this was a very old study, somewhere in 2006, where the massively parallel sequencing has not come in. So they screened for 6 genes, and these are mentioned here, and they identified that probably 17% of them had identified monogenic variant. And of these 100 children, and most of them were sporadic and not familial, extrarenal anomalies are noted in almost in 1/3. Like I said, most commonly cardiac, hearing, and ocular and diabetes. So this was one of the first studies that gave an insight into the monogenics of CAKUT. And subsequently, a lot of work has undergone by various researchers, looking at these kind of single genes or few genes as listed here. Even in the CAKUT study, they identified that 10% of all patients with renal hypodysplasia had variants in either HNF1 beta or PAX2, and a similar finding was also noted when they examined the severe fetuses with severe renal anomalies. As you can see here, around 16% of them had variants, and mostly HNF1 beta or PAX2. So one of the common monogenic variants that we should suspect in a child with CAKUT seems to be like HNF1 beta. And there are various scoring patterns that has come up right from the Belgian group, Elena Lechenflos from 2015 to the most recent in 2024, where they have tried to predict whether the child with CAKUT can have a possible HNF1 beta variant. And in this study, they determined that hypermagnesiuria, hypomagnesemia, pancreatic anomalies, and potassium. When you put this as variables in a scoring pattern, they have a high sensitivity to detect the probability that it may be because of an underlying HNF beta variant. And what is important is that, I don't know whether you see, hypomagnesemia is not absolute value, it is age dependent. So if you take an absolute, what we take as 1.4 or 1.5, you may miss it. So it has to be an age appropriate. When they tried that, a single cutoff, it lost its sensitivity. So what this study shows is that magnesium that we look at should be an age appropriate cutoff, not as the universal one cutoff. So this is some kind of a scoring that there is, but in general, any child with echogenic kidneys or unknown cyst, which is not fitting into a particular phenotype, you should suspect an HNF1 and beta variants, or you should screen for them. But then much later came the whole exome sequencing or the massively screening approach, and one of the first studies were from Europe, and you can see here the screen. This is one of the largest cohort, around 500 individuals with CAKUT, and the yield was around 13% again. So as you can see here, either you screen a panel as an ESCAPE study or you do a massively parallel sequencing, the yield was somehow similar. And there are various factors that can determine an yield, which I come to it later. But what was seen in the study was that if there is a family history of consanguinity, if there is a syndromic association or a severe CAKUT phenotype, that is resulting in kidney failure or severe other urinary manifestations, you are likely to get a genetic etiology. So this is one of the first studies that brought up which children will have probably an identified genetic etiology. That is with the history, family history, syndromic CAKUT, or those with severe CAKUT. So also a lot of work has been done in interpreting this CAKUT during the fetal life. And this is one such study from Germany, where they looked at exome sequencing analysis of more than 1,000 fetal through a coordinatorless or amniotic fluid analysis. Of that, 63 had, or 5%, 6% had CAKUT in this. And in this, you can see here, like everywhere, isolated CAKUT was 2/3, syndromic, those with extrarenal anomalies were 1/3. And as you can see, the yield was only 11% in those with isolated CAKUT, whereas in syndromic, it was positive in almost half of them. So it's again suggesting that looking for this extrarenal anomalies will help you know whether pre-priori whether you're going to get a genetic yield or not. But what is worrying in this is the title. The title says congenital anomaly of kidney and urinary, including renal parenchymal malformations. So they clinically diagnose it as CAKUT. But when they did the genetic testing, they identified in those with isolated CAKUT PKD genes. In those with syndromic CAKUT, in the subset, they identified COPD genes. So clearly, a clinical diagnosis of CAKUT sometimes should be seen with suspicion that it may not be really CAKUT, and in these severe prenatal anomalies, genetic testing should be done to confirm whether it was really a CAKUT or something called a phenocopy, which mimics a CAKUT. Now, this is the most recent study from Europe, and which Sushmata is one of the has contributed patients to this cohort. And this is from Norway and Germany. They screened for CAKUT in the first 3,000 days, that is the first 3 years of life. And they took 100 patients with CAKUT who were diagnosed within the first 3 years of life, and they subjected them to whole exome sequencing. And as you can see here, the yield was 25%, one of the highest yield series of all many of the studies. It was around 25%, and you can see again here, those with extrarenal features, the yield was almost double, close like 41%. And what the study also found that if you are going to do a genetic testing in those who require dialysis within the 3 years of age, the genetic yield is going to be nearly 50%, as opposed to those who had a CAKUT but was not undergoing any form of dialysis in that 3 years of life. So as you can see here, the genetic testing yield will be based not only on the severity but also on presence of extrarenal features and also on the need for dialysis in those especially in the less than 3 years of age. And when we look at the genes, what they identified, only these 25% were accounted by 15 genes. Starting attention of beta 6 to UMOD, PAX2, and so on. And also the syndromic, many of these had syndromic manifestations which were not identified initially, but only after genetic testing, around probably 25 or 30% of them. That included hypoparathyroidism, hyperuricemia, attention deficit, insulin resistance, and so on. So again, the genetic testing utility in CAKUT is beyond the diagnosis. It also helps us uncover the extrarenal manifestations. We also tried to do this genetic testing using a in-house design panel of 31 genes, which had a good coverage. We screened more than 120 children with CAKUT, of which we sequenced 69 of them, close to half of them. Our renal phenotype included mostly, both lower urinary tract abnormalities like reflux and PUV, and some amount of renal hypodysplasia. But we are pretty disappointed with the results that we didn't identify any monogenic variant. Most of them were built into, around 60% of them were built into variant of unknown significance. So, as you can see here, the population in which you are studying also may influence the kind of a genetic yield, and also the kidney, the CAKUT phenotype that you're looking at. Probably our phenotype was predominantly dominated by those with lower urinary tract, where the yield is likely to be less. So, since the yield was not very high with monogenic variants, they started looking at other type of variants, and most common being the copy number variants. So, this is, as you all know, copy number variants are those which results in deletion of more than 1,000 pairs to up to 1 megabase. Either deletions or duplications, and these are called copy number variants. And this is a review article that looked at all the papers that looked at copy number variants in various systemic organ-specific disorders, from fetal malformation, technology, developmental delay, and so on. And you can see that CAKUT is right up there, along with many of the other single organ diseases, suggesting that copy number variant is some of the variant that you should look for when you don't get an yield in exome sequencing. So, to understand the importance of CNV analysis, this is a cohort again from, I think in the US, where they looked at not in just CAKUT, in entire spectrum of monogenic kidney disease. What is the yield of copy number variant? So as you can see here, the diagnostic yield was more or less 25%. Out of that, CAG accounted for 2.5% of that yield. And this CAG was highest seen in congenital anomalies of kidney and urinary tract. Again, suggesting that CNV copy number variants are usually are in among all the kidney diseases. CAKUT is the one condition where you are likely to get a copy number variant. And again, this is a review paper that looked at identified all genomic disorders in various diseases that is also mapped to CAKUT. As you can see here, there are a lot of copy number variants across chromosomes that are associated with CAKUT. But if you look at it, there's always an overlap with CNS and cardiac. So that's again telling us that anyone with CNS or a cardiac malformation also should screen for CAKUT. But of all these regions, 4 regions were very important. One is chromosome 1q, then is 16p, 17q, and 22q. We are all familiar with the 17q, which is the HLF, which includes HLF beta, and 22q is the Dykert syndrome. As you can see here, the CAKUT mostly involved deletions, the red ones, mostly involve the deletions, while the cardiac in the same region are associated with duplications. So this is how in the same region, deletion or duplication can result in different systemic manifestations. The only place where deletion in cardiac is involved is in 22q, Dykert syndrome, where you also get deletions that are associated with CAKUT. Again, emphasizing the fact that any child with a Dykert also should be actually screened with an ultrasound for a potential CAKUT. So overall, when you combine this, that is monogenic variants using an exome sequencing and looking for copy number variant together. This is one study from the Chinese. This was called the Chinese Newborn Genome Project, where they screened 330 newborns diagnosed with CAKUT. And basically, they looked for CNP using whole exome sequencing and not microarray. As you can see, as the yield was around 20% and equally distributed. Not equally, maybe single nucleated variants or more, but you can see the number of CNVs they identified, close to 40% in that cohort. And you can see that a bulk of them were syndromic genes. That is, many of these children diagnosed with CAKUT also had extrarenal manifestations, up to 30% of them. And what is striking here is the most common gene they found here is KMT2D. You have never heard of it probably. It causes, even I didn't hear it till I came, it just causes a cavity syndrome. I mean, I don't know how many of us dentists see it and whether they really screen for CAKUT in those children and how much they find. So depending saying they don't screen for CAKUT. So
we normally, when we get a Kabuki syndrome patient, we do the systemic analysis. When like in our cohort, like in my cohort, I have actually a paper is going to come out from Gangaram on CAKUT. We have patients over there. So the incidence of kidney disorders in the Kabuki syndrome patients that we have got is about 30%. So that paper is actually suggesting that if you see Kabuki syndrome, please
you should screen. Yeah, correct. So that is one thing. Like that when we see CAKUT, we should screen for extrarenal. When others see a syndromic patient, they should screen for CAKUT in many situations. So this clearly tells us that both SNVs and copy number variants are seen in those with CAKUT. So in summary, the genetic yield continues to be low, no doubt. I mean, Shumankar was asking why this confusion, why they don't give yes or no, and why we get no results. And CAKUT is one of the complex disease. It's roughly, as I said, around 25%. But if you carefully select your patients, especially familial history, young onset, those on dialysis, and having parenchymal abnormalities, your likely to your rate is going to be very high. So it depends on what kind of patients you're selecting for genetic testing. And in addition, those with extrarenal manifestations also have a higher yield, probably a double yield. But if you do an unselected randomly doing genetic testing in all CAKUT, there's not much difference in the yield that is observed in children and adults. So clearly, we need to select our patients in whom we should subject for genetic testing. And probably up to date, around 54 genes are known to cause CAKUT either in isolation or syndromic, and the challenge is in interpretation because most of them are autosomal dominant in inheritance. So they obviously can have variable penetrance. In addition, there are other 135 genes that account for various syndromes where in less than 50% of them they have identified CAKUT. So this is something which we will not know, but more a genetist who will be looking at these the first point of contact with these syndromic children who should screen for. There are a list of 135 genes where they should look for CAKUT. In addition, copy number variants we should look for in SIP loci, but I showed you in the previous data 1, 4, 16, 17, and 22. We should look for copy number variant in these genomic regions, especially we are strongly suspecting a familial CAKUT. And what also we need to understand is that there is an overlap in the genotype and phenotype. It's a very pleiotropic disease. When I say pleiotropic, it means that they can produce a different manifestation. This is my last slide. Different manifestation. That is right from kidney agenesis to a reflex to duplicating systems. So, for example, SAL1 causes Tom-Brook syndrome. That is hearing and sensorineural deafness, skeletal anomalies, lung anomalies, and CAKUT. And you can see it can cause this whole spectrum of the manifestations. It can cause renal tubular dysgenesis. It can cause UVJ obstruction, ureterobicycle junction obstruction. So as you can see here, it can cause a lot of this genetics of CAKUT is complex, not only in terms of the yield and also the unilaterality and bilaterality, but also in causing different manifestations of kidney and abnormalities in the kidney and urinary tract. So why should we do? I mean, is it just an academic interest that we're looking at? No, it has a lot of clinical value. One is in establishing a diagnosis. Second is individualizing care by screening for specific complications such as in HLA-beta, PAX2, EYA1. They can have really significant anomaly that can disturb the child. It can also, as the data has shown from the German fetal study, can identify phenocopies, especially polycystic kidney disease and coelopathy. They may look similar on ultrasound. And also, especially HNF1 beta, what we recognize are the neuropsychiatric complications, autism. So, early molecular diagnosis may potentially improve outcome through early and intensive behavioral intervention. So, as you can see here, yes, the yield is low, but it is important in many ways. So, what can be done more to increase the yield? I mean, clearly, it is a complex topic, but probably it is not just Mendelian inheritance pattern alone. There may be something called an oligonucleotide inheritance where multiple genes may cause that phenotype, or it may be a polygenic trait where both the environmental factors and genetic factors may be playing a role. And this is where the data or registries become very important. So, in summary, although the current genetic study indicates a complex genetic basis, the field of CAKUT genetic is constantly growing, and now we have around 40 genomic disorders, 50 genes that are identified to be associated with CAKUT, and the detection rate depends on how we choose the patient for genetic testing. It can be high as 25%. And this is one kidney disease where you should strongly consider a chromosomal microarray or look clearly at the whole genome or a whole exome sequence for copy number variant. But I think a multidisciplinary approach, a collaborative approach, looking at large patient data to know whether it's digenic, oligogenic, or a polygenic inheritance pattern, that remains to be seen. Thank you.